Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. Benign prostatic hyperplasia, BPH, is the leading reason why men visit a urologist, affecting 1 in 2 men between 51 and 60 years of age. While 40 million American men have this condition, which impacts their quality of life, only 12 million are under care. Robert Wood Johnson University Hospital, Somerset, is one of only a handful of hospitals in New Jersey offering aquablation therapy for the treatment of BPH and the only hospital in the RWJBarnabas Health System. On today's show, we will learn about the most common prostate problems, innovative treatment options, and the importance of preventative screenings. We are pleased to welcome Dr. Neil Shah, a board-certified urologist with RWJBarnabas Health Medical Group and Chief of Urology Surgery at Robert Wood Johnson University Hospital, Somerset, and Dr. Biren Saraya, a medical oncologist at Rutgers Cancer Institute and an associate professor of medicine, Division of Medical Oncology at Rutgers Robert Wood Johnson Medical School. Welcome to the show. Thank you both for being here. For the audience, first I want to know a little background on yourself. So Dr. Shah, tell us a little bit about yourself and how you ended up at RWJBarnabas Health Medical Group, as well as the Chief of Urologic Surgery at Robert Wood Johnson University Hospital, Somerset.
Hi, thank you for having me today. So I've been a urologist here in Somerville for about 14 years. I grew up locally, so it was easy for me to come back home. I've been the chair of surgery before. I'm the site director for the residency program at Robert Wood Johnson Somerset, and currently the chief of urology as well. My focuses are just general urology, but I like to focus on benign prostatic disease as well as kidney stones.
Dr. Saraya, tell us a little bit about yourself, about being a medical oncologist at the Rutgers Cancer Institute, an associate professor of medicine, Division of Medical Oncology at the Rutgers Robert Wood Johnson Medical School, who you are. Tell us a little bit about yourself.
Just like Neil, I'm a local kid. I grew up in Central Jersey. I went to Rutgers for undergrad, med school, and residency and fellowship. So I trained here, and I joined faculty here in 2008. And I've been here for almost all the time, some sort of affiliation. For about 3 years, I went to private practice in Summit, but I came back here in 2018, and I practice in New Brunswick, and I see patients, I do education, I train our students, residents, and fellows, and I take care of patients primarily focused on prostate, bladder, kidney, and testicular and penile cancer.
Thank you both, and thank you both for all that you do for our patients. I'm a primary care doctor. I'm an internist. Been here since 1987. And prostate and benign prostatic hypertrophy is it's a subject that's changed immensely. When I started, there was absolutely nothing that we could do for patients other than sending them for a cystoscopy and some type of surgical intervention where they unfortunately didn't do quite well, and we basically watched them for years, and then we came up with treatments. So for the audience, can you tell us what benign prostatic hypertrophy is, who it affects, and are there certain populations that are more at risk for it?
Sure. So benign prostatic hyperplasia means the prostate gets larger. The prostate sits right near the bladder. And so what happens is when the prostate gets larger, it starts putting pressure on the bladder and the urethra, which is the urine channel. So it can cause some symptoms that make it harder for men to urinate. So some of these symptoms include, for example, getting up at night, going frequently during the day, having to run to the bathroom, which is called urgency, blood in the urine. Also, it can cause incontinence, which it causes leakage. Most men start developing it around in their 50s, So between 51 and the age of 60, approximately 50% of men will develop an enlarged prostate. Then that risk increases. So once people are 80, over 85% of men have BPH. Now, that doesn't mean every male will have a symptom, but as men get older, usually you will see some degree of symptomology from an enlarged prostate.
So what we've got is we've got the kidneys up here with the
Correct.
ureters going to the bladder. Just outside the bladder here is the prostate. There's a tube called the urethra that comes out of the bladder that the prostate surrounds that goes out to the real world. So as we get older, that little gland here starts to grow. And it grows both internally and externally. So this hole here, like this, suddenly starts to get smaller and smaller. And as it gets smaller and smaller, that's when we possibly can develop the symptoms which you just described.
Correct. I always use for example, I use like a garden hose. You know, when you squeeze your garden hose in the backyard, you don't get as much pressure from the water anymore. That's what the prostate does to the urethra. So a lot of the treatments we have work on relieving that pressure.
And does benign prostatic hypertrophy or hyperplasia, BPH, lead to prostate cancer?
No, you don't. Prostate cancer can be found with people with men with smaller prostates and also men with larger prostates. So it does not put you at increased risk. Really, what it puts you up for increased risk is more just having a bothersome urinary symptoms. But part of the workup in when we do evaluate someone for prostatic hyperplasia is obviously we take a history. We do a physical examination where we feel the prostate. So it's called a digital rectal exam. So we can feel how big the prostate is. If there's any hard areas that are concerning, we check a urine sample to make sure there's no infection. And then we do a test called the prostate-specific antigen, which can help us identify men where there may be cancer.
So again, the thing to understand is BPH, benign prostatic hypertrophy, is not the same as prostate cancer.
Correct.
Very important for the audience to understand that. Number two is that many of these are actually discovered by their primary care physicians. So up until years ago, guidelines suggested that starting at age 50, we would start doing PSAs and also digital rectal exams. Those guidelines have changed. And again, as a primary care doctor, we don't do as many of the digital exams. We leave that to the specialist, the urologist, to do that. And a lot of it is based on that PSA result. The PSA is something that we discuss with men, and we may want to start doing it at age 40 based on whether there's a family history of prostate cancer or if they have signs or symptoms. And we would like that number to be less than 4 as the guidelines. However, if we do it every year and it goes up greater than 1.0, it may be time for us to think about sending them to the specialist to take a look. Again, years ago, it used to be just watching and avoiding certain medications such as Sudafed, which could actually cause the person to retain the urine, and then we would have to end up sending them to an urgent care center or an ER to have a Foley catheter put in so that they could pass the urine. Then we had certain types of medications which did or did not work. You know, initially we had medications such as Proscar, which, again, for those of us who use it for hair growth, found out that it may shrink the prostate. But again, it's a very slow process. So then when we run into a problem, whether the person is having difficulty urine, you know, they go to a baseball game and they're behind a young kid who it's 1, 2, 3 and they're finished, but they're sitting at the stall and it's taking them minutes to do it. And at the end of it, they still feel as if they haven't emptied their bladder. Then it's time to think about sending them to the urologist. If they notice any blood or any changes in the urination, that's when it's time to send them to the urologist, because the urologist has a multitude of things that can be done to help relieve the symptoms. So tell us, I've got someone like that. What should I do?
So what we always do is obviously examine the patient, but then in terms of treatment options, you know, we tend to start conservative. So we talk about the medications you mentioned. So one of them is called finasteride, which actually reduces the size of the prostate. But like you said, it does take 3 to 6 months to see an effect. Then the second class of medications are called alpha blockers. What they work is to relax the prostate. Think of it like a muscle relaxant. And by relaxing the prostate, it's easier for the urine to come out. So you're not having to go up as much at night. And when you're at a baseball game, like I said, you don't have like 5 people go while you're still there. The other class of medication, which is relatively new, which got approved, is called tadalafil. A lot of men will know that as Cialis, which is also helpful with erections. But at a low dose, it is actually approved for the treatment of these symptoms. So you can use that alone or in conjunction with the other 2 types of medications. So some men who either, one, can't tolerate the medication, B, develop retention where they cannot urinate, or their symptoms are progressing, that's when we start talking about surgical interventions with the patient.
So the medications people need to understand. Initially, we're going to use medications such as finasteride or Proscar, which is the brand name. Some people may go over the counter and try saw palmetto, which may or may not work. Then we have the alpha blockers. That's the Hytrin, that's the doxazosine or Cardura. We have the other medication, tamsulosin or Flomax. So it may be using those medications to help improve the flow and help improve their whole medical care by doing that. And that may hold them for many, many years, or sometimes even longer than that. Now I send them over to you as the urologist to follow up. So tell us, what else do you do?
So the other thing we do, so when we get to the discussion of surgery, we do some tests in the office that help us understand how severe the symptoms are. One is we do an ultrasound of the prostate so we can get an overall size of the prostate. 2, we're able to look in their bladder. It's called cystoscopy. So that's putting a camera into the penis through the urethra so we can look at the inside of the prostate. And then we also do what they call a post-void residual. That is a little bladder scan after you urinate to see if you're retaining urine. So there are some diagnostic tests we do. And then that leads us to discuss surgical options once we have more information. Most of the surgical options we have are what they call transurethral, where we go through the penis with a camera and do the surgery. We do not need to make abdominal incisions really at this point, unless the prostates are 5 times 6 times the normal size. Typically, the prostate, a normal prostate, for reference, should be the size of a walnut. And then the prostate gets bigger from there. But that is the average size of the prostate, just for reference.
And again, so they come to you and you have all of these tests, as you said, an ultrasound of the prostate looking for the size of the prostate and if there's any nodules or abnormalities. The cystoscopy, which unfortunately most men are not very happy about, since you are sticking this tube up there, hopefully as long as they're well lidocaines, it's not that bad. Asking them to urinate and seeing what's called the post-residual volume is. If it's large, that's telling us it's more of a problem for the person. And then it's the possibility of doing the transurethral resection of the prostate or other type of modalities. So other type of modalities other than TURP?
Sure. So it's amazing. It's an amazing time, right? There's so many great options for patients where we can maximize the benefits of surgery while minimizing the side effects. So TURP, the TURP, which is resection using electric current, is still the gold standard, but we have a lot of things that we've now developed that take that same idea, but make it a little bit less invasive. So some of the options we have, so what they call minimally invasive, one is called Resume, which is actually steam ablation. That is where into the prostate using a small needle through a camera, we actually inject steam. And that steam over a 3-month period actually creates the tissue to fall backwards, allowing a larger opening. The benefit of that is there's no incision, there's no cutting, so the risk of scar tissue, incontinence, which is leaking, very low. The other option that's called minimally invasive is something called a UroLift. That is basically where we are actually putting clips into the prostate, and those clips compress the tissue, creating a channel. So imagine it's like opening your curtains in your house. That is what the clips do. And again, the benefit of that, just like the steam, it has very low side effects, and also both have preservation of sexual function, both in terms of erectile dysfunction and also ejaculatory dysfunction.
Dr. Saria, anything to add to this?
No, this is where Dr. Shah and his colleagues are the experts in this. I don't get involved until there's a cancer diagnosis.
Okay, so there are other types of things. Tell us, what is aquablation?
Sure. That is one of the newer technologies out there. So for reference, the idea is instead of using heat to resect tissue, it is actually using a water jet. It's almost just like a power washer for your patio, for example. So we put a handpiece, a camera, once again, through the urethra, and then using that power washer, so to speak, that water jet, we're able to remove tissue. The benefit of aquablation versus these other procedures is when you remove it with a TURP, for example, you don't know how much tissue you're taking. So with aquablation, at the same time, we're putting an ultrasound probe into the rectum so we can actually visualize how much tissue we're cutting out. And it's robotically guided. So we contour, we tell the robot how much tissue we want to remove, and then the robot will actually control the water jet and remove the tissue we wanted the robot to remove.
Very interesting stuff. It's a good thing that you were good with your Nintendo when you were a kid.
Yes, it's really exciting because we're able to take so much tissue here and still do it through the urethra. Normally, we would have had to make an incision and open up the bladder. Now, a procedure that was done open or robotically now can be done transurethral. And the other benefit of this procedure is it can treat almost any size prostate. Some of these other prostate surgeries have requirements where the prostate has to be a certain size. And once you pass that size, you can't do that procedure anymore. So this is almost like one size fits all, so to speak, in terms of prostate procedures.
Amazing stuff. So in addition to BPH, of course, the other thing we have to be concerned about is prostate cancer. So Dr. Saria, tell us a little bit about prostate cancer, common signs, symptoms, how it's detected, and what we can do to hopefully reduce it.
So prostate cancer arising from the prostate, most times, as you sort of talked about earlier, we do screen for it in age-appropriate men, and after discussion of risk and benefits, because while PSA, the prostate-specific antigen blood test, is a good screening test, it does require conversation with your primary doctor about what risk do we take, what risk are of the screening test. And the reason is because when there is a prostate cancer that Dr. Shah and my colleagues are diagnosed when there's high PSA or on examination, there's a nodule found, we have to talk about what to do with it. And there are different treatment options, including not addressing the cancer. So there are many men in the right appropriate age when the cancer is so slow growing that we may recommend not doing anything about it, which is exactly why having conversations with your primary doctor about the risk and benefits, your family history really makes a difference. In terms of besides screening, what can we do? There is no other significant things that we can do. We just know that there are some families, but this is a high risk. And so we want to sort of screen for them earlier on. And typically, if there's a family history of breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, maybe in between 40 and 50 is the right time to screen for prostate cancer with the blood test, seeing the urologist examination. Otherwise healthy men 50 or plus. And again, most important thing for me is having that conversation with your doctor about your risk, your benefits, and what is that you want to sort of get out of the screening test. That is probably the most important thing.
Again, very important, the conversation with the patient. One, of course, the family history. If someone has a dad, brother that has prostate cancer, the person's going to be wanting to be screened much sooner, etc. Sort of like when, again, someone has colon cancer, we do colonoscopies earlier. We do colorectal cancer screening earlier. If a woman has a sister, mother, a relative that has it, we're going to do more screening. If someone has a father, brother that has prostate, there's going to be more screening. At the same time, the PSA, as you know, is not a very accurate test. it's got its pros, cons, and we've tried to do things such as a free percentage of PSA, and it's still not a great test. The good news is, at the same time, we have an ultrasound which can look at the prostate itself, looking for nodules or abnormalities, and nowadays we also have the MRI of the prostate, which also helps guide the treatment of the prostate also. The other good news is that prostate cancer is one of those so-called, in quotes, good cancers, because if you get it, you have a very high 5-year survival rate. And so can you walk us through the various treatment options that patients have when they access prostate cancer treatment at RWJBarnabas Health and the Rutgers Cancer Institute?
Absolutely. So as you said, there is a great survival. And I would say actually go a bit further, there's actually high chance of cure for many, if not most patients. So screening has a good role because it can help us find cancer early, detect early, and then get the right doctor, whether it's someone like Dr. Shah and a urology oncologist, or someone who's a radiation doctor, and someone like me who's a medical oncologist who gives drugs for cancer. We really try to, once a biopsy is done, we try to identify a risk. What's the likelihood the cancer would grow outside the prostate? And what's the likelihood cancer would come back after their treatment? So we sort of try to put into low risk, intermediate risk, or high risk. Someone who has a lower risk disease, choices for treatment include doing something about the cancer, like surgery or radiation, or just doing surveillance with our colleagues in urology. If they have intermediate risk, surveillance still has a role, but many times we want to intervene with some sort of curative intent treatment, which is surgery or radiation with hormone therapy. So short-term hormone therapy for about 6 months or so. In terms of high risk, where we think there's a high risk cancer is already outside the prostate, is based on what it looks on the MRI, what it looks with the other scans, and what it looks like biologically in the biopsy. And for high risk, we recommend doing either surgery or radiation with longer-term hormone therapy and close follow-up, because there is a risk of cancer coming back, which can still be curable. So if someone had a surgery and with high-risk disease and cancer, the PSA, for example, comes back higher, we can still cure with radiation after that. So this is the curative setting where we have probably more than 70% of patients can be cured when they find early, even in high-risk disease.
And again, a lot of that's based on the patient's Gleason score,
Yeah.
which tells where what kind of cells, how far it is, if there's any other involvement. Yeah. And again, since you are part of RWJBarnabas Health and the Rutgers Cancer Institute, you also have access to clinical trials for patients at the Rutgers Cancer Center, which is the only NCI-designated comprehensive cancer center in New Jersey. So can you tell us about what patients can expect?
Yeah. So first of all, I think just a word or two about clinical trials. So, I talked about all the treatment we can do to get to high cure rates. Well, how do we get there? We got there because years ago and in the decades past, we studied how to best take care of our patients and how to get better cure rates. And that's with clinical trials. And clinical trials take many different forms. Clinical trials about how to best do surgical interventions, how to best do radiation, how much hormone therapy to give, what other treatments to give. And so when I talked to it about the low risk, intermediate risk, and high risk based on the Gleason score and what it looks like on the MRI, we also have studies in each of these settings. So it doesn't matter what the cancer is, we likely have a study where we're trying to figure out how can we do better. Because from our perspective, even if something has a 90% cure rate, we are I wanted to know how we get to 95 and 100. Or if there's toxicity, how do you minimize the toxicity? Because it's about letting patients, letting our neighbors live a normal life for as long and as well as possible. So the clinical trials play a big role in it. And at Rutgers, Robert Wood Johnson, and Rutgers Cancer Institute, we have trials in surgery, what kind of surgical techniques we use, and how do we use drug therapy in addition to surgery, radiation, based on genomic testing, how much to radiate and what kind of drugs to give with it. If the cancer happens to be outside of prostate, metastatic, how do we best treat that? There are several trials, probably about a dozen trials that we have that patients have access to.
Again, because you are part of Rutgers Cancer Institute, you have the whole team approach from start to finish.
We do.
The nurse navigator, the excellent surgeons, the excellent urologists, oncologists such as yourself, radiation oncologists, and the fact that you have tumor boards where people all get together, surgeons, oncologists, radiation people, in order to come up with the best plan. And even if that best plan means watchful waiting, that's good for the patient. A 90-year-old who ends up with prostate cancer, watchful waiting is probably the right way to go. So it's really based on who the patient is and what's the best treatment options, which is what is important when someone has this kind of a diagnosis, why it's so important that they go to a place that has a team approach, such as the Rutgers Cancer Institute.
I couldn't have said it better.
Is there any recommendations for prostate cancer prevention for the audience?
From my perspective, I think the biggest thing is screening and really looking at the risk and family history is the most important thing. I think that's what I sort of look at and recommend. In those patients of mine who have family history, we'll do genetic testing to see if there are any specific genes that are mutated that may not only imply a risk for them, but also their family, their siblings, their kids. And so we do have those conversations with our patients and their families.
Again, you have a geneticist that can help with all of that.
Yeah,
Not very many places have such an animal.
Yeah.
Dr. Shah, recommendations for patients, 40, 50, 60. As a primary care doctor, what should I recommend for them?
I think, in addition to what Dr. Shah was saying, I think it's really important to just for any type of just health in general, eating healthy, lowering cholesterol. There have been some studies showing that maybe these things can lead to prostate enlargement. So I think it's really important just to, in general, take good, health care of yourself. But for me, it's just, important that patients know that we have specialists who can really take care of any problem they may have when it comes to the prostate, whether it be from benign disease or prostate cancer. That at Robert Wood, we really have a great team and we're really on the cutting edge of therapy for our patients.
And that we're all together as one. So if something can't be done at RWJ Somerset, they can easily be transported over to RWJ New Brunswick or the Rutgers Cancer Institute and get the same excellent care. And since everyone is all on the same forum, the EPIC system, nothing is lost in between. It's not having to start from square one if they have to go down there.
Correct. There's great continuity of care between even the two campuses. For example, we have urology residents that we have at Somerset that also go to New Brunswick. So that is also very helpful in terms of continuity of care. And then even all the physicians, it's all so easy to communicate now. Each of us either have cell phones or phones. So when you're in the same system, I think as a patient, just know that your physicians are communicating behind the scenes.
So again, goes back to good healthy eating, good exercise, keep yourself in good health. Try not to be overweight, don't smoke.
Correct.
Enjoy life, and see your regular primary care doctor as needed, including starting at age 40, at least once a year, to see for screening type of cancer cases, not only prostate cancer, but for colon cancer, breast cancer. Stop smoking if you smoke. And know that right here within our community, we have the best quality of care, and that we have the only NCI-based designated comprehensive cancer center. So if, unfortunately, you have that diagnosis, this is where you should go. Thank you both for being here, and thank you both for what you do for our community.
Thank you very much.
Thank you very much for having us.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 844-CANCERNJ. For more information about cancer services at RWJBarnabas Health, please visit us at www.rwjbh.org/beatcancer.